So I'm going to talk this morning about pregnancy and heart disease. You're going to get some more routine sort of talks about the things you see more frequently. Hopefully you won't see many women with serious heart conditions during their pregnancy, but you may occasionally. You'll certainly see lots of women with symptoms relating to their pregnancy that may be caused by heart problems, and we'll talk about that as we go along. The main emphasis for concentrating on heart disease and pregnancy is shown in the latest and previous surveys of maternal and fetal mortality. So it's now the Embrace studies that come out. It used to be the mortality in maternal and child health, but they've changed the name and they've changed the base to Oxford. But this graph really explains well why we worry about the heart. So as you're all aware, over the last however many years, certainly the last 100 years, maternal mortality has dropped from very high levels to very low levels. So that mortality now is really very unusual for a mother to die during pregnancy. And a majority of that reduction in mortality, certainly in recent years, has been a reduction in the direct causes of maternal mortality. So things like the management of preeclampsia and eclampsia have improved, the management of sepsis during pregnancy. However, the management of the indirect causes, or the mortality from the indirect causes of mortality during pregnancy, haven't changed to a great extent. And you'll see on this graph that they've really stayed the same. And the commonest cause of mortality during pregnancy, the indirect cause of mortality during pregnancy, is cardiac causes. So the first bar in this graph is a concoction of unusual causes, but the second bar, which is the main single cause of mortality, is cardiac disease, and that's why we concentrate so much on managing women with known cardiac disease during pregnancy and trying to pick up women who develop cardiac problems during pregnancy, and we see both. And the reason for that is because of the physiology of the heart during pregnancy. So during the pregnancy, during the whole pregnancy, you have to increase your cardiac output. A woman has to increase her cardiac output by about 40 to 50%, and even more if she has a twin pregnancy. A woman does that by increasing the stroke volume of her heart, but primarily by increasing her heart rate. So a heart rate of 100, 110 during pregnancy is not particularly unusual. It may cause palpitations, for instance, which is one of the reasons women will come and talk to you about a potential cardiac symptom during their pregnancy. Palpitations are very common during pregnancy. The blood pressure will also change. So during pregnancy, during the first trimester, the blood pressure tends to drop. Second trimester, it starts to plateau off, and in the third trimester will go up. And in some women, if they've got pre-existing hypertension or they're prone to getting hypertension in the future, then hypertension will become quite a significant problem during their third trimester. And of course, there's women who develop preeclampsia who will become hypertensive. So we have to bear that in mind. A woman, however, will drop their systemic vascular resistance during pregnancy, which is the reason the blood pressure drops during the first trimester. And that's a good thing for many cardiac problems. So many cardiac problems, such as mitral regurgitation, are treated by vasodilatation. If you're going to drop your systemic vascular resistance as part of the pregnancy, then that's a good thing for something like mitral regurgitation. It's equivalent to taking an ACE inhibitor, for instance. So we'll skip that. And then, of course, during labour, there has to be very rapid increases in cardiac output. And this could be a big problem if you're unable to produce that increase in cardiac output. So during contractions in particular, the cardiac output needs to increase almost double during the second stage of labour. And towards the end of labour, then there will be an issue with loss of blood potentially. So there are big fluid shifts at the point of the baby being delivered in the few hours afterwards. And there are some cardiac conditions that cannot cope with those fluid shifts and changes in volume. So you can see there's potential for lots of problems during pregnancy if you have pre-existing cardiac disease. So I'm going to start off just going through the important, serious conditions of the heart that can lead to problems during the pregnancy. So these are the ones which are associated with a potentially poor outcome. And the first is outflow tract obstruction. And all of these, you'll see, are conditions where you cannot increase the cardiac output. So these pictures show you patients with aortic stenosis. You'll see the first image on the left is a bicuspid stenosed aortic valve. Then you'll see an echo picture on the right there of a tightly stenosed aortic valve. And below you'll see pictures of a patient who had significant mitral stenosis. And whether it be inflow obstruction or outflow obstruction, it's really difficult to increase your cardiac output. And as a result, patients with these conditions, if they're significant, do very poorly during pregnancy. What we know is that if you've got significant aortic stenosis or significant mitral stenosis, it's better to treat those before embarking on a pregnancy. And we'll talk about preconception advice a little later in the talk. But if these appear during pregnancy, they're first diagnosed, and we see, particularly in the clinic I run at the Royal London, where we have a population that's changing all the time, and we have groups of women who've come from the developing world, we will often pick up unknown valvular disease during the pregnancy because these women haven't had checks when they were at home, say in South Asia or South America, for instance. And if we pick up significant aortic stenosis or mitral stenosis, it may be that you'll have to send these patients for an intervention during their pregnancy. We occasionally will pick up a woman at an early stage in pregnancy with severe aortic stenosis, and then we have to have a discussion with the woman and her family about the potential problems and the possibility of having a termination rather than going through the pregnancy with a high risk. But if we pick up these lesions in late in the first trimester or in the second trimester, or the woman doesn't want to contemplate a therapeutic abortion, then there have been cases, well-documented cases, of intervening even on aortic stenosis and sending a woman for an aortic valve replacement and the baby surviving. With mitral stenosis, there's a very good body of evidence that you can do a successful balloon valvuloplasty during the pregnancy, and this is done most frequently in the developing world. So if you went to a cardiac unit in Bombay or Delhi, they would be expert at doing this. We will do it only maybe once a year or less in our unit, but you can get a very good result with a good outcome for the fetus as well. Perhaps the most serious condition if you're pregnant is if you have significant pulmonary hypertension. So women who've got known pulmonary hypertension, whether it be as a result of a primary condition, as shown here, for instance, on the left, or as a result, so this is primary pulmonary hypertension on the left, or as a result of a large VSD as seen on the right. If they've got significant pulmonary hypertension, their maternal mortality is at least 50%, if not more. And so we would counsel very hard to avoid pregnancy if you have these known conditions. And ideally, these women are brought through initially the pediatric service and then an adult congenital or an adolescent congenital heart disease program, and someone would have spoken to them about the risks of pregnancy long before they get to the stage where pregnancy would potentially be an issue, and they will be using effective contraception. But having said that, the drive towards wanting to be a mother is so great, and occasionally these conditions haven't been diagnosed properly, especially in women coming from abroad, and they will present in pregnancy, with a pregnancy. And in those cases, if they come early enough, we would strongly recommend therapeutic abortion, but occasionally they would decline. And I've certainly looked after one woman who had significant complex congenital heart disease and was pregnant, didn't want to have an abortion, and sadly lost her life as a result of that. So it's a really serious condition. The next section is discussing patients with reduced left ventricular function. Many of these patients at this age group, if they do have reduced ventricular function, will have a dilated cardiomyopathy. And again, if you have a woman of childbearing age coming to our clinics, we would talk to them about the risks of pregnancy at an early stage. And they would have, depending on the severity of left ventricular dysfunction, they would have a very significant risk of morbidity and significant mortality if they were to get pregnant. So some of these will be patients with pre-existing left ventricular dysfunction. Sadly, more often now, we're seeing patients who have had significant myocardial infarcts prior to getting pregnant. So we see a group of women in their early 40s who are embarking often on first pregnancies because of career and so forth. who have had myocardial infarcts in the past. So a case that comes to mind, I looked after a young woman who, I think she was 28, firstly when I was a registrar, and then at the early stage of my career, which is now as a consultant, which is now nearly 20 years long, who presented with a large anterior infarct. She came from a family with a terrible history of early onset coronary disease. She was a heavy smoker. She ate terribly and had a very high cholesterol. And she presented with this big anterior infarct. And she did remarkably well. She had an intervention to her left anterior descending artery. I looked after her for a few years, and then she was discharged from clinic. And the next time I saw her was about 15 years on, and she presented age 42 with her first ever pregnancy. And she was incredibly excited about being pregnant. And we re-echoed her, and her ejection fraction was still around about 30-35%. So we counselled her and explained to her the risks of progressing with the pregnancy. She was determined to have a baby. She felt it was her only ever chance. We never turn patients away. We run clinics both at the Royal London and at Queen's Hospital in Romford. And when we counsel women about the risks of their pregnancy, we always say if you decide to get pregnant or if you don't wish to have a therapeutic abortion, we are more than happy to look after you, and we will see you on a very regular basis and take you through the pregnancy. And she decided she was going to go ahead with the pregnancy. At that stage, it was early pregnancy. We withdrew her ACE inhibitor because an ACE inhibitor is strongly contraindicated because it'll affect the fetal kidney. We cut back her diuretics completely. She wasn't on very much, in fact, at that stage. We got her onto nitrates. She stayed on aspirin, and we beta blocked her, all of which is safe during pregnancy. And she did really well during the pregnancy. She was starting to get a little bit breathless. And then in the last week or so of pregnancy, and then just after term, she went into pulmonary edema. But we treated that with diuretics. We got it through, and thank goodness she was fine. And it was just a wonderful moment when she came back to clinic 6 weeks postpartum. And this woman I'd known for a long time with a baby, and she was just so happy. So although it's risky, getting a woman through this can be incredibly satisfying. The other group of patients that we see with poor left ventricular function are those that develop it as a result of their pregnancy. So about 1 in 5,000 women will develop what we call a peripartum cardiomyopathy, and that can be really very serious. We think the numbers are actually underestimated. We see it on a regular basis, maybe because we echo women who come to us with breathlessness, and we pick up peripartum cardiomyopathies. The most severe ones tend to be picked up right at the end of the pregnancy, late in the third trimester, and often early in the postpartum period. So if you see a woman who's postpartum, maybe two weeks postpartum, who's suddenly become very breathless since she's had the baby, or even a few months postpartum, just think this may be quite significant. And occasionally we will pick up women with really very severe left ventricular dysfunction. One that comes to mind is an Albanian lady who's a late booker at Queen's Hospital, was admitted very breathless at about 32 weeks, had crackles in her chest. She had an echo done that day and showed a 15% ejection fraction, so a really very poor left ventricular output. And the obstetricians decided they were going to deliver her, because in an obstetrician's mind, if you've got a woman who's ill, the first thing you want to do, as you do say in eclampsia, is you want to get the baby out. And I actually went into theatre and said, stop, because the problem with these patients is that they go off really big time when you deliver them, and delivering her in a DGH without tertiary cardiac facilities was potentially a disaster. And we managed to get her transferred to the Royal Brompton, who have an arrangement with Chelsea and Westminster, so they can deliver in their cardiac unit. She was delivered, she went into cardiogenic shock almost immediately, and was put onto ECMO, which is extracorporeal oxygen transfer. So she basically had an artificial heart system keeping her going. Sadly, she was on ECMO for a period of time. She then had a left ventricular assist device put in, but she became severely septic and sadly lost her fight for life about 6 weeks postpartum, which was a shame. But on the other hand, we've seen women with very severe cardiomyopathies like this who've got through, and at least a third, if not a half, will recover, and their left ventricular function will go back to normal. We don't completely understand the etiology and the process, but it clearly seems to have something to do with estrogens, and then the stress of pregnancy on top of that. But if you can get them through the initial period, they will recover. There was an excellent case of a woman with a twin pregnancy who developed a relatively early peripartum cardiomyopathy. She went to Queen Charlotte's, was delivered, and then had a left ventricular assist device attached, and over the first 6 months postpartum, her heart recovered. So she had the LVAD, kept her going, and her heart recovered. We tend to advise that there's a high risk of a subsequent pregnancy, but there have been many women who've recovered and then had a further pregnancy without serious problems, but it's clearly an increased risk. The next group of patients that we're concerned about are patients who've got problems with their left ventricular, with their aorta. So the classic case would be someone with Marfan's, family history of Marfan's, or with some other similar connective tissue disorder. But Marfan's is the one we know most about. And what we know is that during pregnancy, even with a normal aorta and no Marfan's, there's a slightly increased risk of aortic dissection. It's the pressure that's put on the aorta. But if you have a known problem, particularly Marfan's, the significant thing to look for before the pregnancy is whether the aortic root is dilated. And the greater the aortic root is dilated, the higher the risk of a dissection during pregnancy. And we worry about these patients a lot. We do serial scans of their aortic root, usually with echo, but with an MRI at the beginning of pregnancy. An MRI is safe during pregnancy. But even with a patient who has a normal aortic root but no Marfan's at the beginning of pregnancy, there's an increased risk of dissection. So we counsel the patients very carefully. If they're known to have a dilated root and they're keen on pregnancy, we would counsel them to have the aortic root replaced before they embark on pregnancy. If they have a successful root replacement with some caveats, then the risk is much less than it would be if you have an unreplaced root that's dilated at the beginning of pregnancy. So patients who present with severe chest pain during pregnancy need to be dealt with urgently. We then worry a great deal about patients with prosthetic valves, whether it be mitral or aortic. We see the occasional right-sided valves, but that's very unusual. And the reason we worry primarily is if they've got a mechanical valve. Previously, there was a lot of concern if you have a tissue valve that it will age and deteriorate very quickly as a result of pregnancy. There's some debate about whether that's the case or not. But on the whole, if you've got a young woman who's having a valve replacement, there's a concern about putting a tissue valve in because they may need to have a whole series of operations during their life. Although there may be an argument, and often it's made, and a decision is made to put a prosthetic valve with a tissue prosthetic valve in initially, allow them to have a family, and then put a mechanical valve in after they've decided they've finished their family. And the reason for that is illustrated very clearly and rather tragically by this case. This is the post-mortem specimen from the case that made me interested in pregnancy and heart disease. And I'll tell you a little about this patient. She was a young woman, about 19, had a valve replacement for congenital mitral valve disease when she was about 12. And they put a small valve in because she was very small. She was only about 4'10". Even when we saw her, maybe 5 foot when she was looked after during pregnancy. So she was a very small girl, and she had a small valve put in. And this valve was put in at St Mary's, and she lived in the King George area. And this occurred only a few months into my consultant post. And when she got pregnant, she was seen in the anticoagulation clinic where she was usually managed, and they swapped her to unfractionated heparin. It was before the days of low molecular weight heparin. She was run on unfractionated heparin. They monitored it as best they could. She said she was going to St Mary's to have her checks of her heart, but she wasn't because the bus fare was too much, and her boyfriend decided they couldn't afford it. And as a result, at around about 34 weeks pregnant, she became very breathless. And she was seen by the GP. GP thought she had pneumonia. It's quite understandable. And she then had PV bleeding. And she came in as an emergency, and she had a placenta previa, and she was bleeding heavily. She was clearly very breathless. She was seen by the medical registrar on call, who again thought she probably had pneumonia, hadn't seen pregnant women with heart disease before. And she went for an emergency C-section. She had the emergency C-section, and she went off immediately. She was woken up, went into crushing pulmonary edema, was re-anesthetized, re-tubed, and I was called to see her. And she was an extremis on ITU. And I TOE'd her at that time, and the valve had a big lump of clot. The valve was neither opening or closing, so it was stuck half open. There was severe mitral regurgitation and stenosis, and not surprisingly, she was in a terrible way. We took her to London Chest, but we lost her. Perhaps in hindsight, we should have given her thrombolysis, but it was the first time I dealt with such a case. And you can see here You can see where the mitral valve is, and there's a big lump of clot and pannus around it. So this has been building up over some time. And it was at this point I realized that we needed a local service to see pregnant women with known heart disease throughout their pregnancy. And we've seen numerous women now since then with prosthetic valves and mechanical prosthetic valves. And what we used to do is we would stop their warfarin, because warfarin is teratogenic in the first trimester. We'd give them low molecular weight heparin now for the first trimester, swap them back to warfarin for the rest of the pregnancy, and then swap back to heparin for the last week or two. And we did that for quite a long time. The problem with that is that even during the second and third trimester, warfarin is a problem. There's a high attrition rate of babies because warfarin crosses the placenta and the babies are prone to bleeds into the brain. And so in recent years, there's been a general trend towards using low molecular weight heparin throughout the pregnancy. So if you have a woman who has a mechanical valve, and one or two of you may have that of childbearing age, as soon as they get pregnant, they need to go to an anticoagulation clinic. We swap them to Clexane. We measure something called the anti-10A antibody level every other week, and we have a target range, a bit like an INR, and we give them aspirin as well. And a vast majority of our women have done well, but there is a problem. Even if you run things well, there's a risk. This was a young woman, a teacher, with a mitral prosthesis. During her pregnancy, she was on Clexane and aspirin. The levels were ideal, but even so, she presented breathless, had signs of pulmonary edema, and the valve on, this is a normal echo, and it's not opening properly. It's difficult for you to appreciate, but here, on the lower slide, the flow of blood, the velocity of the flow of blood across the mitral valve is very high, and that suggests that the valve is partially occluded. And she'd noticed that the valve had stopped clicking. And then she actually went to another centre with tertiary care services available, and she was given thrombolysis. And halfway through the thrombolysis, she started hearing the valve clicking again. And you'll see here on this second Doppler slide, the velocity of blood has dropped significantly back to normal. And the clot cleared. She was managed on warfarin for the rest of the pregnancy, had a healthy child, and has avoided a further pregnancy. So even with Clexane, there's a risk. Now, the group of patients we see quite frequently now, more often than we used to, are women who develop coronary problems during pregnancy. And in many cases, this will present acutely with a first myocardial infarct. And classically, this would be as a result of either a coronary dissection or thrombus in the coronary. And this is a case, lady presented with what is a posterior infarct. She's got ST depression in the septal leads, classic of a posterior infarct. And the treatment for these patients goes straight to the cath lab. Even before we did primary PCI, we would take these patients to the cath lab rather than thrombolizing them. And I'll try and use the arrow here. Yeah, so she's got an occluded circumflex artery due to these appearances are classical pictures of a coronary dissection. We ballooned and stented the whole vessel. One of my colleagues did this and had an excellent result. But more recently, things have changed, and we seem to see more cases of patients with classic, standard atheromatous coronary disease who develop myocardial infarcts. This was a young woman. This actually happened about 4 weeks after the Moamba case. Things were not quite like they used to be. And this woman presented acutely to the ambulance service with what is a big inferior myocardial infarct with quite widespread ST elevation. She came to the lab on a day I happened to be there at London Chest. It's difficult to get into a right coronary, but I hope you can make out that just down here, the dye stops and there's an occlusion. So she's got a right coronary occlusion. We put a wire through. And we direct stented it. So we put a stent directly there without ballooning it. And the final images were excellent. Unfortunately, this is what happened next. Within a few seconds, so she arrested, went to VF. And we did 3 cycles of CPR on this woman with a 19-week fetus. Unfortunately, we got her back, as we would expect in that circumstance. And she went up to the ward. Having done the clinics, the joint cardiac clinics for a long time, I can actually do a reasonable fetal ultrasound these days, but in this particular instance, I waited for an obstetric colleague to come across to London Chest, and about 5 hours later, he scanned her fetus and the baby was fine. And it was another great example where the patient came back. We'd seen her on and off during the rest of her pregnancy, and she delivered at about 40 weeks. She was quite an older patient. She was a 42-year-old, had a previous TIA, in fact, heavy smoker from Dagenham, and she came back with a healthy baby. And again, it was a delight to see. So they're the severe, worrying situations. There are many cardiac conditions that are well tolerated. Leaking valves, as I said, are helped by the fact that you vasodilate. Many of the congenital anomalies like ASDs, small VSDs, are very well tolerated. Hypertrophic cardiomyopathy is well tolerated. Of course, you've got to counsel the woman the risk of the child having this condition, and you need to be very careful about fluid balance around the time of delivery, and most of the arrhythmias. So a lot of women come with arrhythmias, SVTs. We see lots of women with ventricular ectopics. We even see some with heart block and with ventricular tachycardias. Heart block can be paced during pregnancy. I've paced women during pregnancy. My colleagues now tend to do that at Barts for us. And that can be done very successfully with low exposure to radiation. And in all our time, particularly the SVTs that worry women, they all worry that this is going to happen whilst they're in labour. And we think because in labour you have quite marked vagal tone, these arrhythmias don't tend to happen as much as you would expect. And in the last 18 years of doing these clinics, I've only seen one woman who's actually gone into SVT during labour. You can give them adenosine very safely, has very short half-life and causes no problem. So they don't tend to cause a problem. We reassure them hugely. The other issue, of course, is drugs, antihypertensives. We've already said that ACE inhibitors are a risk. Classically, we use methyl dopa labetalol, but we can very comfortably use the dihydropyridine calcium antagonist, amlodipine, nifedipine. We can use hydralazine. Sometimes you need to use a combination. The obstetricians are great at looking after the hypertensives, and they run their own hypertensive clinic. They don't need us there. So that's usually quite straightforward. Antiarrhythmics, we definitely can't use amiodarone. We can use beta blockers. They're very safe. The data that came out in years gone by about beta blockers was on huge doses in rats, and in practice we use bisoprolol, metoprolol very freely without any problems. They don't tend to cause growth retardation. You can use flecainide during pregnancy if you have to, so we will use that in some cases. And other drugs we need to check individually, but those can be used, and they're the most frequently used. Heart failure drugs, again, ACE inhibitors, the ARBs we can't use, but we tend to swap to other vasodilators like a nitrate or hydralazine. We try and limit the use of diuretics as far as possible. Angina, again, beta blockers are fine, calcium antagonists are fine, nitrates are fine. So we don't tend to have a problem. And when it comes to anticoagulants, we've already talked about clexane versus warfarin, but the antiplatelet drugs, we know that clopidogrel is fine. We've used that because we've had patients who've been stented prior to pregnancy, and we've used clopidogrel and aspirin throughout pregnancy without a serious problem. Obviously, there'd be a concern at the time of a caesarean section, or if they were to have a tear, and you may have to withdraw the clopidogrel temporarily to allow bleeding to stop. And we've seen a few problems with quite significant hematomas as a result. The presentations, these are the things you're likely to see women with who they'll complain of breathlessness. On the whole, we regard breathlessness as a normal part of pregnancy. You've got your diaphragm stented by the fetus, and most breathing in normal times is because of diaphragmatic movement, so they're going to use their intercostal muscles more and they'll feel more breathless. They're putting weight on so things become harder. So it can be quite difficult to distinguish between what's normal for pregnancy and what's not. An echo will help with that. Occasionally, if you've got a patient who's acutely breathless, you've obviously got to think of a pulmonary embolus, which is significantly more common during pregnancy. Murmurs. We see lots of women with murmurs during pregnancy, and we try and triage them out of the main pregnancy clinic because almost all women will have a flow murmur during pregnancy. I've been doing it for years, so I can say whether it's a flow murmur or not just by listening, but it become quite difficult if they've got a loud flow murmur. So in that case, it's reasonable to refer them, and we will echo them. Echo obviously is perfectly safe during pregnancy. And palpitations, as I said, almost all women will have a degree of tachycardia. Other types of palpitations, particularly ventricular ectopics, are much more common during pregnancy. Almost never cause a problem. We reassure the women. That's the case. We may do an echo to check ventricular function is fine. Occasionally you'll see new SVTs. They often settle down after pregnancy. If not, they can be treated in the same way as SVTs do in other situations. Chest pain, we obviously worry about possible ischemic heart disease if they're very high risk. It's pretty unusual to pick up an ischemic heart disease with angina rather than a myocardial infarct. We send occasional patients for more detailed investigation. We rarely find that they have ischemic heart disease. Chest pain is quite common. Costochondritis is more common. Aches and pains are not unusual in pregnancy, of course. And then dizzy or syncope. That's so common. Fainting is almost a normal part of pregnancy, and it's trying to differentiate between whether it's significant or not. Vast majority of cases, it turns out, it's just part of the pregnancy. So how do we manage these patients? Well, you've already heard we have a high-risk clinic. We do it 2 places if you need to refer patients, either to the Royal London or to Queen's Hospital. We run the clinics, usually myself and obstetrician. Lots of people come to watch the clinic. The cardiology trainees need to tick off that they've been to some of these clinics. So there's often a lot of people in the clinic. And we work closely with our anaesthetic colleagues and with other specialists if we need them. And we try and anticipate problems. And as I've mentioned on several occasions, if someone's known to have underlying cardiac disease during their young life, we will say to them, be careful about pregnancy. Come and talk to us. Come and see us as soon as you become pregnant. We have to remember to do genetic counselling if they have a potentially hereditary condition. And if they've got a hereditary condition, we will very frequently send them to have a fetal echo done in a specialist unit. And then, of course, we have to remember postpartum that we want to avoid a further risk to the mother, and therefore we'll talk to them about appropriate contraception. And that may be dependent on the underlying problem. So the take-home points for this are, many cardiac conditions are actually very well tolerated. And part of our job is to reassure women that they're not going to have a problem. I haven't gone into whether they should have caesarean sections or not, mode of delivery. That's another big issue. And women often come with preconceptions and have been told the wrong thing by other colleagues. Often my colleagues in cardiology will say, oh, you're going to have a C-section. We almost never send them for C-sections because of their heart problems. We try and anticipate and counsel them about problems. We monitor them very closely, usually monthly, and we remember to talk to them about contraception afterwards. Thank you.